This conference will now be recorded.
Good morning, everyone. Am I audible? Is it okay for you? Are you able to listen to me?
Yes, ma'am.
Okay. There is some delay, right? Okay, we have completed most of the part of diabetes. As I already told you that we completed the entire thing of diabetes. Just one more small thing, that is monogenic form of diabetes, which are not per se the diabetes which we talked about in the previous classes. Means we talked either about type 1 or type 2, which are nothing but either because of deficiency of insulin or because of its resistance at the peripheral tissue, you get diabetes. Those are the two forms of diabetes which we talked up to now, like previous classes. But there are other forms of diabetes, which is apart from the type 1 and type 2, which might not be because of exactly the same pathology which we discussed previously. It might be just because of the genetical mutations or some genome range at the level of gene itself, there is some defect. Those are these few forms of diabetes. It's not necessary for you to at this level of MBBS. You need not remember everything given in this slide. I just wanted to tell only the few, might be these are more in number, the slides, but very few are the ones which you need to remember. I will just go upon those and you will get to know. See, when we are talking about monogenic forms of diabetes, I mean to say about MODY, that is maturity onset diabetes in young, and neonatal diabetes mellitus, mitochondrial diabetes, and insulin resistance and lipodystrophy syndromes. Monogenic form of diabetes is nothing but a single gene mutation which is occurring. Because of that, you have the result of either impaired insulin secretion from the pancreatic beta cells or insulin resistance. Up to before, whatever we talked is not just because of the genetical. These things are happening in our body per se because of different pathophysiology of type 1 and type 2. Here in this monogenic forms, it's per se because of the gene mutation, these things are happening. Whatever we talked in previously, either because of atherosclerosis and all, type 1 and type 2, both with the different pathologies here occurring. Either it might be a genetical, either it may be a viral related in type 1 diabetes, or it might be because of obesity, metabolic syndrome, insulin resistance in case of type 2. These two, if they are occurring because of genetical defect, that is monogenic form of diabetes. And these are misclassified. Mostly why are we talking about is sometimes these may be responding to the OHA, which per se type 1 might not be responding to. So we need to know that there is this form of diabetes which can be treated in a different perspective. But usually we misclassify them either as type 2 or type 1 or type 2 because these are the ones which we commonly see. About 5% of all cases of diabetes are monogenic forms of diabetes, but what we are identifying is very less because of the lack of adequate lab tests and all. Because mostly we tend to give FBS, PPS, and label a diagnosis rather than go for a genetic mutation because we can't, for the sake of 5% population, we don't want to screen the entire 100% people. So that is with it. And Modi, 1 to 2% of all diabetes cases in Europe with prevalence of 2.1 to
Female
4.6.
voice.
Any problem? With a prevalence of 2.1 to 4.6 per 1 lakh of general population, you have the cases recorded. And only 10 to 20% of MODY genes are identified. Either it might be in Japan, China, and 12% in case of India. Neonatal diabetes is like around 1 in 2 lakhs live birth, and the prevalence of mitochondrial diabetes mellitus is 0.4 to 1.5%. And then variety of lipodystrophy is more than 300 cases reported, just only 300 entire worldwide. And these are the genes involved in the mechanism of either MODY and neonatal diabetes mellitus. Uh, See, if you see in MODY, you have different genes. You need not remember all of these. What are the specific genes which you are supposed to remember? I will tell you in the further slides. In the slides, you just have to know that there are many genes involved in MODY and many in case of neonatal diabetes. There are overlap of few in between neonatal and MODY. And this is the diagram which you already know when we were talking about how the glucose enters into the body and how the insulin is secreted. You remember, right? Through GLUT2 channels, glucose is entering, and through glucokinase, it becomes glucose 6 phosphate and gives the energy. And that energy is responsible for the opening of the potassium channels. Further, the potassium channels, and this is the channel where the sulfonylurea usually blocks. Sulfonylurea glows and blocks this. That is the reason how the insulin is secreted. Further, the calcium enters because of depolarization, and then this results in fusion of the vesicle from the which are blebbing out of the endoplasmic reticulum into the cell membrane and release of insulin. This is the mechanism how insulin is secreted, and there are different channels in this pathway also. Those are, see here, glucokinase is there in the second step. This glucokinase is involved in second type of MODY. You come across this channel KCNJ12, J11, ABCC8, neonatal diabetes. These are involved in neonatal diabetes. And if you come across this particular gene after the glucokinase, where the ATP near the mitochondrial level, where the ATP is produced, there is something called as A324 3G gene. This is involved in mitochondrial diabetes. And further, for the calcium release and the vesicles of insulin to fuse through the cell membrane, and for the liberation of the insulin, these following genes are involved. They are HNF4 alpha, 1 alpha, IPF1, HNF1 beta, neuro D1, and PAX4, and INS. These all are involved in this mechanism. So see, whatever the MODY or mitochondrial diabetes or neonatal diabetes, whatever the things we are talking in this class are all dealing with the genes which are responsible for encoding the proteins in this particular diagram, which is well known to you, where you have seen the sulfonylurea concept. So this is the, so now you got a gross idea, I suppose. These are the literature studies where you are talking about the, 1 minute. See, this is the literature study. Previous are the literature studies. In here, you have, you know, about different types of MODYs and the genes which are involved in that particular MODY. MODY, nothing but maturity onset, diabetes in young, and the gene which is involved and the locus of the gene, and the gene, what is the gene, particular gene doing the functions, and where is it affecting. These all are the ones which you are going to see in this table. This is the only table which is important either for your entrance or for your class, or I think in the entire class. If you remember this single slide, that is sufficient for you. You need not read further also, because they are not going to ask much, but in your entrance exams and all, you can expect a few of the MCQs from this particular slide. Okay. And also, if you are going to any quiz or anything also, it is well asked, this question. Now stop telling me attendance, and at the end of the class you give me the attendance. Okay. Coming to MODI 1, it is hepatocyte nuclear factor 4, HNF4 alpha. You need to remember this. One is important. It is 4 alpha. And where is it? It is in 20q chromosome. And the gene function is, it is transcription factor, nuclear factor. It is a nuclear factor where you are releasing or synthesizing the insulin, or for the process of insulin release and all. Those are transcription factor, HNF 4 alpha transcription factor. That is what you have to remember. Then coming to second type of MODI, that is glucokinase. This gene is defective. Glucokinase is an enzyme. The gene responsible for the production of that particular enzyme is glucokinase gene. If that gene is defective, then you have MODI 2. And here the chromosome level is 7p, and gene function is it hexokinase 4. At that level it is going to act, and yeah, at that level it is going to act. And so, and also it is going to be there are going to be defects in pancreas and liver. Liver also in case of MODI 2. Okay, and then coming to 3, that is HNF1 alpha, that is chromosome 12q, and it is a transcription factor as all, and it is also involving the pancreas and kidneys. Kidneys, where are they involved, can be an MCQ in the MODI 3. And then coming to MODI 4, insulin promoter factor 1, IPF1, and it is a transcription factor, domain, and it is involved in case of pancreatic problems. Excuse me. Then coming to MODI 5, that is HNF1 beta, and chromosome involved is 17q. It is also a transcription factor, and you find problems with kidney and pancreas. There will be an MCQ asking where there is polycystic kidney disease, or where there are cysts and all. Kidney is involved in case of MODI 3 and 5. 3, you remember where you are getting the 5, you remember where you are getting the polycystic kidney disease. And then MODI 6 is neurodifferentiation 1, neurogenic differentiation 1. It is a chromosome number 2, and it is a transcription factor, and it is also involved in pancreatic abnormalities. Then coming to MODI 7, that is KLF11, that is triple like factor 11. It is on chromosome 2p25. It is a transforming growth factor beta, inducible early growth response, and it is also having some pancreas. Most of them are with pancreatitis. It is about the insulin. Just you need to remember that if it is 2, you have additionally liver involved, and if it is 3, it is kidney involved. If it is 5, kidneys are mostly involved, and something like cystic disease of kidney. And then coming to MODI 8, bile salt dependent lipase cell. Locus is on chromosome 9, Q34. It's very tough to remember all these chromosome numbers. Just remember the MODI number and the gene name involved in it. That is sufficient. And apart from that, whatever the few questions I told you when I'm talking about kidney involvement and all. And then endocrine cells of pancreas synthesize insulin and are involved in the pathogenesis of diabetes mellitus, and exocrine cells are involved in the pathogenesis of pancreatic malabsorption. That is MODI 8, and pancreas is involved as obviously. And paired domain gene 4, PAX. It is MODI 9, and it is also a transcription factor. And here also the pancreas is involved. MODI 10 is insulin. The beta cells of Langhans are at the problem. So you have deficiency of insulin gene, and also further insulin, leading to diabetes. Nuclear factor kappa B is involved. And MODI 11, it is tyrosine kinase, B lymphocyte specific gene, and it is in the on the chromosome 8p23 and p22. It is tyrosine kinase. Tyrosine kinase is a second messenger system for most of the receptors. And coming to the thing, MIN6 beta cells, oral beta cells are destroyed. So either pancreas, entire thing is pancreas. Just one thing which you need to focus is 2 is liver, 3 is kidney, 5 is more of kidney. So you remember the MODI and the genes involved in it. Here in this MODI types, need not go through all. I will just mention abnormal beta cell transcription leading to deficient insulin secretion, and because of that you can have rare neonatal hyperinsulinism, low triglyceride, diabetes prone to microvascular complications, and sensitive to sulfonylurea. See, initially also I told you why we should not misidentify MODI as type 1, because type 1 is not responsive to sulfonylureas, whereas MODI is responsive to sulfonylurea. So if you think in terms of MODI, you can give a trial of sulfonylurea. If at all you are not thinking in terms of MODI, then you go with the insulin. So whenever you have a doubt, it's always better to rule out by giving a shot of sulfonylurea. If the patient responds, it should be MODI. And reduce glucose sensitivity due to deficient phosphorylation and impaired glycogen storage. And it is common around 30 to 50%. Features impaired fasting glucose and increment of less than 3, no GTT. Mild diabetes, usually there is no anti-diabetic treatment needed in case of type 2. Okay, whereas type 1, you see they are sensitive to sulfonylurea in the sense you can give them sulfonylurea. In the two, it is a very mild form of diabetes. Usually it goes unnoticed, or where you are not where the patient is not requiring any kind of diabetic management. Coming to the three, there is abnormal gene transcription causing deficient insulin secretion and progressive beta cell failure. It is common in 30 to 50%, and high penetrance is there. Glycosuria and microvascular complications can occur, and you can give a trial of sulfonylurea here also. If they are not responding to sulfonylurea, then switch to insulin. Then coming to the next fourth form, impaired pancreatic development, pancreatic agenesis in homozygous state. So it is very rare and average at a rate of 35 years. At the time they will have the onset, and they respond to oral anti-diabetic drugs. When they are not responding to that, then go with insulin. So these all are these all are as we have discussed. C4 is insulin promoter factor. Here the problem is near that. But it is very rare. Among them, the common ones are either 2 or 3 glucokinase, where you are not requiring any treatment, or 3 where you are requiring insulin, sulfonylurea plus insulin. What are the genes involved? First one is HNF4 alpha, second one is glucokinase, and third one is HNF1 alpha. So 1 alpha is the one where you are talking about the common one. 1 alpha and glucokinase. And the rare one is IPF, insulin promoter factor. Fifth one is HNF 1 beta. So here abnormal gene transcription causes deficient insulin secretion, and it is rare form diabetes with extra pancreatic manifestations like renal cyst, dysplasia, genital abnormalities in female, azoospermia in male, large variability in phenotype. Insulin treatment might be needed because of severe damage to the production of insulin. So you see here, the important thing which I already told you, fifth one is more of to do with pancreatic, renal cysts. So whenever they ask renal cyst or dysplasia or genitalia abnormality in female or azoospermia in male, then you go with the 5. 5 is nothing but HNF 1 beta. Okay. So by now, all the 5 you should be knowing or remembering collectively. 4 alpha, glucokinase, 1 alpha, then insulin promoting factor, and then 1 beta. These are the 5 which you can by heart by now. This is nothing but by hearting because these all are genes. Uh, that is meant to be, I mean, you can only remember. There is nothing like shortcut for uh, or a mechanism behind those genes also. So genes you need to by heart. So only those first five are the ones important. I think if at all they ask you something in the question, they'll ask you about the first 5 only. And coming to the sixth variety is neurodifferentiation 1, as I already told you. So what is happening? Abnormal development of beta cell function is occurring, and it is very rare, and adult onset diabetes occurs in this patient. And then coming to 7, KLF11 or transcription growth factor. Here there is a reduced glucose sensitivity of the beta cells are there and tumor suppressor cells, and it is also very rare. Rest of the forms are very rare. If at all you have to remember, you have to remember the eighth form, which is autosomal dominant, and ketoacidosis is expected in the ninth form, and diabetes diagnosed less than 20 years. Sulfonylurea and insulin late in the follow-up can be given in case of 10. And BLK gene tyrosine kinase expressed in pancreatic islets, that is also very rare, high penetrance with the body mass index. So in this table, only that pancreatic and renal cyst and female genital abnormality. Everything you go with the fifth one, HNF1 beta, and then ketoacidosis is in case of 9. That is PAX4 transcription factor involvement. That is this for the 2 slides. If you remember this 2 slides, that is it. I think it's the end of the class like that. But just I will brush up through rest of the varieties, which are not very important at your level, but it is okay to just know about. MODI 12, where you are seeing the defect in ABCC8 gene, adenosine triphosphate binding cassette subfamily, CFTR, MRP, member 8, chromosome 11p is involved. And MODI 13, KCNJ11, potassium channel invert rectifying currents are involved. And MODI 14 is caused by heterogeneous mutations in APPL1 gene on chromosome 3p14. So coming to the clinical features, usually these people are around 25 years or less than that. That's the reason you always have a confusion with that of type 1 diabetes. As you already know in the name itself, MODI, maturity onset, that should be around 25 years or less than that. And mark family history of diabetes in at least 2 or preferentially 3 consecutive generations, and a similar phenotype shared by the diabetic family members, usually autosomal dominant inheritance. Okay. It is also important for you to know about the dominant and recessive inheritance in that chart along with the genes. If at all there is family history of diabetes, you can think in terms of MODI, because type 1 diabetes uh, there is no family history, and here there is absence of obesity and insulin resistance, which is usually present in type 2. See, it is not like type 1, it is not like type 2, so it is a different one compared to these two. And there won't be any kind of ketosis because this hyperglycemia is not very severe where they form ketosis or ketoacidosis. And usually there is mild hyperglycemia without the need of insulin therapy for about around 5 years. And negative test for autoantibodies against pancreatic beta cells You usually don't have. GAD65 and IA2 are the ones which are present in type 1 diabetes. Here there are, it is not an autoimmune disease. It's not to deal with the antibodies. It is just the maturity onset because of the genetical defect. So it is different from that of type 1. Type 1 you have autoimmunity, GAD65 antibodies are present. Sometimes there can be a lag period of 10 years, and the clinical phenotype, they may vary substantially among patients with the same MODY genotype, even among members in the same MODY family also. And gene to gene and gene to environmental interactions are always responsible for it. And if you do significant C-peptide levels, even in a patient on insulin treatment more than 5 years, it will be usually more than zero point 0.2 nanomoles per liter, or urinary C-peptide creatinine ratio is more than zero point 0.2 nanomole per millimole. Insulin levels are in normal range, though inappropriately low for the degree of hyperglycemia, suggesting a primary defect in the beta cell function. Low insulin requirements are required for this patient if you are going to treat him on insulin. Usual dose is zero point 0.5 unit per kg per day, but here you can give less than 0.5 units. Okay, see here the insulin is produced in a normal range, but if at all you are having, you ate a sweet where your sugars are piking up to like 300 400, at the time what is insulin supposed to do? It is go at, it should be increased. Suppose it should be increased up to 25, but here in case of MODY it can be only up to 10 or 15 max. So that is the difference with the MODY. Usual patients are having the normal sugar levels and normal insulin levels. But in case that patient eats some hyperglycemic diet, sweets, chocolate, what is happening? The insulin is not going to increase. It is going to remain at the baseline itself. That is the problem with this case of with these kind of patients. Coming to MODY specific types, coming to three, there is mutation in the transcription factor HNF1 alpha and altered gene expression for proteins involved in GLUT2 and key enzyme pyruvate kinase in the mitochondrial glucose metabolism in secretory defect collectrins regulate exocytosis and beta cell growth, and insulin gene transcription can be involved. Reduce beta cell proliferation and increase apoptosis, progressive decline in beta cell function. And apoptotic cells, pancreatic it's not strong pancreatic proteins, which are gene proteins, they are they are also involved and are marker of the pathological process. And there is decline in the beta cell insulin secretion by around 1 to 4% per year, and it is slightly reduced, there can be slightly reduced pancreatic volume. So when you do ultrasound or something, you can definitely notice a very decrease, small pancreas, and usually less than 25 years, and 63% of the kids are carriers, and 79 by 35 years. The number increases. Usually less than 25 years it's onset, but as the age continues, then they come to be noticed by a physician, or they themselves come to notice that. The location of mutation in HNF1 alpha is determining the age of onset of diabetes, and control the transcription of SGLT2 or downregulation of SGLT2 channels, which are present in the proximal tubule, which is responsible for absorption of the most amount of glucose. And relative euglycemia before the appearance of overt hyperglycemia and diagnosis of diabetes occurs much later in life. And FBS is usually normal, but 2 hours 75 gram OGTT is more than 5 millimole per liter. These patients can have postprandial hyperglycemia, and then because of high sugar levels, there is always glycosuria whenever it is there. And the non-diabetic mutation carriers, glycosuria occurs after OGGT even when the blood glucose level remains normal. C-peptide levels are low because insulin is there, but they are detectable. Whereas in type 1 diabetes, it's not detectable. And the management, what you are going to do is marked sensitivity to low dose sulfonylurea can be observed. So you can always try sulfonylurea as first line management. 20 to 40 milligrams of glycoside or 1.5 or 25 to 2.5 glibenclamide can be given daily. There can five-fold greater response can be there. Response like to sulfonylureas than with metformin. So you need not give them metformin, directly go with sulfonylurea. And glycemic control, sulfonylurea is initiated initiated initially, and then as per requirement insulin is added. And if at all you start them on insulin initially, gradually try to shift them to sulfonylurea. And FPS lowering effect than that in BMI and glycemic index, glycemia match type 2 diabetes mellitus patients usually observe. Remaining insulin dependent, they remain insulin dependent for 5 to 20 years. Further, they remain insulin dependent further after the initial step when the sulfonylureas um, are not taken. During pregnancy, you give the sulfonylurea, uh, which is the safest sulfonylurea in pregnancy. It is a glyburide or glibenclamide. That is the one which can be given in pregnancy. Rest others are contraindicated during pregnancy. Strict glycemic control during pregnancy is mandatory. Maternal hyperglycemia lowers the age of MODY manifestations in the offspring by more than 10 years. And extrapancreatic features which you do observe are raised HDL and incidence of CAD can occur. Statin therapy, that is the reason you are going to start in this patient, and hepatic adenomas can be present. So, in diabetes patients, what is the abnormality in the lipid profile? What is happening? Is going to be HDL is going to decrease, and what is the next other mechanism? Triglyceride is going to increase, not the cholesterol. If you see the Asian population mostly, it's not the LDL which is per se increasing, it is the triglycerides. So always when you are marking, this is one of the MCQ which is asked. So I'm asking you. If you are going to, in the Asians, you don't think about LDL and you don't want the lipid profile concentrated on the LDL. It's very important for you to look triglycerides also in the case of Asian population, because their triglycerides are more elevated, and triglycerides are the one responsible for the atherosclerosis and cardiovascular morbidity. So check for triglyceride levels when you are dealing with the lipid profile in case of diabetes. And if you come across type 1, it's nothing similar to that of 3. That is 1 alpha, and here it is 4 alpha. HNF 4 alpha. And you get macrosomia by increasing the insulin secretion in utero. And there is no glycosuria usually, and there is decreased HDL, apolipoprotein A1, A2, B, C3, and raised LDL is present. LDL is nothing but which is representing cholesterol. So whenever LDL is increased, you think that cholesterol is elevated. And if you are coming to other lipoproteins, they are the ones which are responsible for tightly packing up the cholesterol and transporting to different organs. This is the same picture which you can understand. Coming to MODI 2, there is homozygous loss of functional mutation and complete deficiency of glucokinase. Uh, and heterozygous, if there is a homozygous loss, if it is heterozygous loss, there is impaired conversion of glucose to glucose 6-phosphate and reduced glucose sensing, and insulin secretion starts at a higher threshold and blood glucose levels of 6 to 7 instead of 5. See, that is what I was telling in the initial slides. Usually a patient has to respond, he doesn't respond to a particular peak. Normal baseline is maintained, but when there is peak, this patient is not responding. If at all he responds to the peak, he responds to an exaggerated or increased peak. See, if at all he has to respond at 5, he is responding at 6 or 7. That is the bar, or that is the deficiency which is expected in this case. And there is right shift in the dose response curve or glucose induced insulin secretion. And coming to clinical features, there is mild fasting hyperglycemia and from birth, and slight deterioration with age, less than 50% progressing to over diabetes, and 2-hour OGDT is small. There is a very little increase. Whereas in type 1, you thought like there is more of OGDT increase, and glucokinase mutations can involve liver, and there is reduced hepatic glycogen synthesis and stores, and increase in glucogenesis. Then can be fasting hyperglycemia. C peptides are usually normal without the need of treatment. HbA1c values are near normal without secondary complications. Typically diagnosed in pregnancy, and the prevalence of glucokinase MODY was found to be around 0.5 to 1% in GDM, and BMI less than 25 and FPS more than 99 differentiates glucokinase MODY from the common GDM. Affected family members may not have been diagnosed, and autosomal dominant pattern is not evident. Pregnancy and glucokinase mutation. This is one thing you can go through. There is heterozygous glucokinase mutation in the fetus, and there is reduced insulin-mediated fetal growth and reduced birth weight, and maternal glucokinase mutations and absent in fetus, maternal hyperglycemia and enhancing fetal insulin secretion, and increases the birth weight. Fetal growth scans are surrogates for fetal genotype, and during pregnancy, insulin to prevent macrosomia when A1C is more than 75th percentile. Outside the pregnancy, oral anti-diabetic or insulin is not recommended, as hyperglycemia is mild and complications are rare, and medications has been shown to have minimal effect. Modify here renal cyst diabetes, you need to remember pancreatic hyperplasia with agenesis of dorsal and caudal part, and exocrine deficiency is there. Renal cyst and malformations like horseshoe kidney, single kidney, familiar hypoplastic, glomerular cystic kidney disease can all be present. And the spectrum varies at one time, diabetes dominates, and other urinary tract malformations can occur. C-peptide is low, but it is detectable. And babies carrying HNF1 beta, low birth weight can occur as a result of reduced insulin secretion in the in utero, and transient neonatal diabetes mellitus. Contrary to other modiforms, it has higher rate of spontaneous mutations, and family history is unreliable, and penetrance is variable, and diabetes is diagnosed right from birth to 61 years. Annual screening is recommended, and there is no sulfonylurea sensitivity, so it requires insulin, low dose insulin. You can start despite of insulin resistance because you don't have other things. Metformin and pioglitazone can be started initially. Both beta cell dysfunction and insulin resistance can occur, and they can lead to diabetes mellitus, and lowers HDL cholesterol level and increases the triglyceride levels. It is a very dangerous combo. That is what we are seeing in case of diabetes. Extrapancreatic manifestations, 50% have end-stage renal failure, less than 45 years, and less than 6% can have the normal renal function. Hyperuricemia can occur, which is associated with gout, and there is raised liver enzymes and hypomagnesemia. Familial hyperuricemic nephropathy can occur. Chromophobe RCC, HNF1 beta tumor suppressor gene is identified, and genitourinary malformations like aplasia of vas differentia and of vagina and rudimentary uterus, bicornuate uterus, double vagina can occur. Renal ultrasound every 2 years to screening for the chromophobe RCC. Screen for diabetes early in non-diabetic mutational carriers. Coming to MODI 7, that is KLF11, is a zinc finger transcription factor, pancreatic islet cells, and binds to and activates the insulin gene promoter in the presence of glucose. KLF11 is a glucose-inducing regulator of insulin gene. MODI 8, it is a pancreatic SNR cell, also known as bile salt stimulated lipase or pancreatic juice. Hydrolysis of cholesterol esters occurs, and heterozygous mutations, pancreatic atrophy, fibrosis, and lipometasis can occur. MODI 9, PANX4 transcription factor, and it is a differentiation of insulin producing beta cells. Its deficiency favors alpha sulfate at the expense of beta cell lineages, and they are prone to ketosis and diabetes. Coming to MODI 10, it is 80% de novo mutations inherited, subsequently in autosomal dominant pattern, and mutated insulin. It reduces reduced bioavailability and receptor binding capacity is there. They accumulate because of that. The more of insulin or a mutated one is accumulating in the endoplasmic reticulum, and it increases the intracellular stress, which can lead to apoptosis. Homozygous mutations of INS, a defective insulin folding in endoplasmic reticulum, structurally defective insulin, these all get packed up there, and they also can have the same fate of stress and apoptosis, which can lead to severe hyperglycemia and diabetic ketoacidosis. Heterozygous mutations with or without diabetes, as both normal and mutant insulins, compensate for the defect by overproducing normal insulin, and MODI 10 GD. MODI 11. BLK non-receptor tyrosine kinase of SRC family of proto-oncogen, which is a stimulator of insulin synthesis and secretion via transcription factor, PDX1 and NKX6.1, and these patients are obese. Pancreatic development abnormality, endocrine pancreas and exocrine both are involved. 4, 5, 6, 8 are involved in endocrine pancreas, that is insulin, which we all talked about. Almost all the modis, these in specific. And exocrine are specifically involved in 4, 5, 7, 8, and 9. I think you remember this slide, the first initial slide, just a brusher. First one is 4 alpha, and it is having the beta cell dysfunction. So neonatal hyperinsulinemia and low triglycerides can be there. You can treat them with sulfonylurea. Then second one is glucokinase, and it is very milder form. So just dietary restriction is sufficient. Third one is HNF1 alpha. Here it is also sensitive to sulfonylurea. Fourth one is IPF1. Here it is diet or oral anti-diabetic medication or insulin. You can start. The fifth one is 1 beta. Here the renal anomalies, genital abnormalities, pancreatic hyperplasia can occur. Here you need to give them on insulin. They are not responsive to to sulfonylureas. Neuro D1 is sixth one. Here you will start them on OAD or insulin. Next 7, 8, Seventh one is similar to type 2 diabetes, where you're giving them oral antidiabetics or insulin. And then coming to eighth one cell, that where you are giving, where it is an exocrine sufficiency and lipometasis, both are present. And important thing, you remember that it is exocrine is involved, and OAD or insulin is the treatment. Pax4, there can be possible ketoacidosis. Eighth, you remember exocrine. Ninth, you remember possible ketoacidosis. Along with that, treatment is diet, OAD, and insulin. Next, coming to 10 INS, same, you can give the oral diabetics or insulin. The last ABCC811, where you can give sulfonylurea for treatment. That will be sufficient. This is the thing you need to know about this. This table is nice. You can take a screenshot or something, and you can keep this slide for your remembrance. If you see daily once or like once in few days, but not leaving completely, can make you remember. So there's a brief differences between type 1, type 2 and MODY. Usually the age of onset of MODY is less than 25 years. Type 1 is 5 to 20 years. Type 2 is more than 25 years. Based on this, we usually get confused type 1 and MODY. And the family history is there for MODY, which is around 60 to 95%, as it is genetically mediated. Type 2, it is 10 to 40%, whereas type 1, it is less than 10%. Coming to the inheritance mode, type MODY is autosomal dominant. Type 2 is polygenic. And obesity, insulin resistance, metabolic syndrome are usually seen in type 2, not in case of type 1 or MODY. Beta cell antibodies are present in type 1 diabetes, not in rest other types. And C peptide is normal in MODY, because the baseline level of sugars or like insulin is normal. It is only not able to hike up when the escalation has occurred. So usual C-peptide level is normal. Whereas in case of type 1, it is undetectable. Whereas in type 2, it can be high or low, depending on the phase where insulin, how insulin is secreted, and depending on how much resistance the patient has. And usual treatment for MODY is for MODY 1, 3, and 4, it is usually sulfonylurea, whereas type 1 it is insulin, whereas for type 2 it is metformin, the baseline drug. Now the important one, now you know about MODY. Now comes the next one, latent onset disease, where you're combining MODY and LADA. So multi-generation family history is usually present in MODY, not in case of LADA. Anti-pancreatic antibodies is usually present in LADA. Okay, C-peptide after several years from diagnosis also is present in MODY, whereas not present in case of LADA. Renal and genital tract abnormalities may occur in few forms, especially type 4 of MODY, whereas not that case in case of LADA. And accompanying autoimmune disease can occur with LADA along with that of uh, type 1 insulin, type 1 diabetes. HLA, DR3, DR4 are the ones which are present in several patients of MODY, and over half of the cases of LADA. Usually patient diagnosed before 45 years of age and diagnosis less than 6 months. You do the genetic testing for neonatal diabetes and insulin from diagnosis, DKA, positive beta cell antibodies. If anything is there, it is type 1 diabetes. C-peptide levels you do, it is more than 0.4, 0.2. Then you think of, and if at all there is no autoantibody, then you think in terms of MODY and do genetic testing. If it is diagnosed less than 30 years and there is absence of insulin resistance and diabetes in at least one individuals of less than 25 years and at least last 2 generations, then it might not be type 2, then think for MODY testing. Then neonatal diabetes, it is usually mutations of KIR6.2 and sulfonylurea channels. It is transcription factor gene. Glucokinase gene can be affected, and less than 6 months is the onset. And due to intrauterine insulin deficiency, what is having small for gestational age with diminished subcutaneous fat, baby can occur. They have failure to thrive and dehydration and sepsis with or without diabetic ketoacidosis. First week of life with hyperglycemia and negative urinary ketones can be present. Lower mean birth weights compared to that of rest of the diabetes patients. Sulfonylurea can be tried, but it is if satisfactory glycemic control is not achieved, insulin should be started, and insulin requirement is lower than that of the other types. Disappearance during infancy by 18 weeks of age, and it can reappear in adult life at around 14 years. These are all the similar monogenic forms which are not very much required. Coming to the syndromes. Some important syndromes which can be asked, I will just touch upon. Wolfram syndrome, it is WFS1 gene mutation. It is a transmembrane protein and activation of UPR, unfolded protein response to mitigate endoplasmic reticulum stress. And it has a recessive mutation and increased susceptibility to ER stress mediated apoptosis, so beta cells can occur. So in this Wolfram syndrome, the patient can have, you can remember by this mnemonic DIDM OAD, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness can be seen. It is associated with early onset diabetes and it requires insulin. In this case, you can find the patients with diabetes insipidus and sensory neural hearing abnormalities, renal tract abnormalities, cerebral ataxia, and myoclonus, and depression, upper GI bleeding, ulceration can occur, primary gonadal atrophy can be seen, and neurorespiratory death occurs by 30 years, and retinal thinning as a marker of disease progression can be identified. Next, renal Fanconi syndrome, glycosuria, galactosuria, aminoaciduria, proteinuria, phosphaturia, short stature, rickets, poor growth, hepatomegaly, galactose intolerance. These all can be seen in renal Fanconi's anemia. Here, the entire proximal convoluted proximal tubule is affected. So there is even SGLT2 level to also blocked all the channels. There is usually postprandial hyperglycemia, IgT, and diabetes. Heterogeneous mutations and isolated glycosuria and proteinuria can occur, and high dose thiamine, sulfonylurea, or insulin can be given as per treatment. In mitochondrial diabetes, the one thing which I want you to remember is the affected parent is usually mother. From mother, the affected gene is inherited to the child. Children of an affected male are not at risk of carrying the mutation because the mitochondria from mother is usually given to the baby, not the father's. So if father is affected, nothing happens to the baby in mitochondrial inheritance. But if it is the mother involved, that will be carried on to the next generation. These are the last few slides. I'll just brush up fast. And there is a reduction of functional respiratory enzyme complex and reduced ATP generation in this case. And finally, whatever the reason, if there is hyperglycemia and free radical damage, this can cause damage and cell death. The different mitochondrial diseases are the ones which are given in this picture. You can see mitochondrial inherited diabetes mellitus, MELAS, with diabetes mellitus and deafness, and then Wolfram syndrome, where diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, which we already talked, and KSS, Kearns-Sayre syndrome. It is external ophthalmoplegia, cardiac conduction block can be there, retinal degeneration, deafness, and dragged red muscle fibers can be there, and proximal myopathy and cerebellar ataxia can also be seen. So in this patient, usually the mutation is A3243G gene, which I already discussed initially. Age of onset and requirement of insulin depend on heteroplasmic and the level of mutated mitochondrial DNA. Neurosensory defects can be present, GDM can be there, and the person is usually lean. Diabetic ketoacidosis in one-third patient, and C-peptide levels are low, but they are detectable. Normal insulin sensitivity is present in this case. Management is first you give insulin secretor works, and then you start insulin within 4 years of time. Metformin is contraindicated as it causes lactic acidosis, and here in mitochondrial endopathie, lactic acidosis is some common finding which we see. So don't give metformin in this case. Coenzyme Q10. 2400 to 3000 milligram per day, and thiamine replacement can be instituted. They reduce progression of insulin secretory defect and cardiomyopathy and hearing loss in early stages. In pregnancy, magnesium sulfate should be avoided as it complicates the calcium in mitochondrial membranes and may exacerbate damage. Higher rate of lactic acidosis and intolerance to statin in mitochondrial diabetes as it reduces coenzyme Q10. The first degree family member should be screened for the mutation and provided with the genetic counseling. Reported clinical manifestations are diabetes, sensory neural hearing loss, cardiac issues like conduction abnormality in W by W, atrial fibrillation, and sick sinus syndrome, cardiomyopathy, congestive heart failure can be there. And the neurological varieties like MELAS, mitochondrial myopathy, basal ganglia calcification, cerebellar ataxia, oculomotor palsy, and weakness and exercise intolerance can be there. Neuropsychiatric disorders like MR, dementia, depression, psychosis can be there. Ophthalmic are macular pattern dystrophy and cataracts. Retinal are focal segmental glomerular, renal are focal segmental glomerular sclerosis, and hyalinized glomeruli, and myocyte necrosis in afferent arterioles and small arteries. And complications of pregnancy are placenta accreta and preterm labor can occur. Other monogenic forms at the last among the things we discussed, the last one is I told you like mutations of monogenic forms of insulin resistance. Those are these. They are mutations in insulin receptor gene, receptor defect at INSR, or post receptor defect AKT2. They can occur, or inherited lipodystrophies which are partial or generalized. Here is the insulin receptor and the mutation where wherever the mutations, the second signaling pathways, wherever the mutations can be there, it's given in this picture. Not very much required. The Leprosel syndrome, Donahue syndrome, the one thing which you can remember, Ramsden-Wendel, type A insulin resistance syndrome. These three other monogenic insulin resistance syndromes. Leprosel or Donahue syndrome is autosomal recessive, low birth weight, IUGR, characteristic dysmorphic features they patient present with or the baby has, and they do not survive beyond the infancy. And Rapson-Mendel syndrome is autosomal recessive. Acanthosis nigrosus and growth retardation can occur. And dysplastic dentition, nails, coarse facial features, and lack of subcutaneous fat and pineal hyperplasia can occur. Renal abnormalities like medullary sponge disease and nephrocalcinosis can occur. Paradoxical fasting hypoglycemia, the diagnosis. And diabetes mellitus in the later ages of life can be there. Coming to type A insulin resistance syndrome, Hiran syndrome, it can be autosomal dominant recessive, insulin resistance, acanthosis nigrosus, PCOS, hirsutism, signs of virilization can be there, and the patient can be young and lean. So management are metformin and thiazolidines, insulin therapy required as per the beta cell function. Glycemic control is often poor despite very high dose of insulin. U500 insulin reduces insulin volumes required, and the role of IGF-1 stimulates glucose uptake and glycogen storage. And the inherited lipodystrophies are familial partial lipodystrophy, congenital generalized lipodystrophy. Familial partial or autosomal dominant peripheral subcutaneous fat is lost. They are not obese, and mutations in LMN and PPARG. PPARG mutations can lead to phenotypically similar to the LMNA mutations. Hypertension is more common in these patients. Dunning-Kruger lipodystrophy. It is also a mutation in LMNA gene. Gradual peripheral subcutaneous fat is lost from the body, and the muscle hypertrophy, it can simulate muscular appearance, and the fat loss from the anterior abdomen and chest can occur. Hepatic steatosis can occur. Diabetes mellitus in the late adolescent age. Hypertriglyceridemia can be present. Acanthosis and PCOS can be there, and cardiovascular mortality is high. Are you ready to take the questions? Diagnosis, usually the brief one I'm telling you, usually they are less than 25 years with a family history. They are not obese with low HbA1c levels, and they have negative pancreatic autoantibody testing, and the definitive diagnosis is only by genetic testing. This is the summary of monogenic form of diabetes or MODY. Genetic testing methods are screening methods, Sanger DNA sequencing, and denaturing high performance liquid chromatography, and partial or whole gene deletions can be detected. 3% of MODY genes, but they cannot be detected by sequencing. Multiplex ligation dependent probe amplification technique detect gene deletions where a diagnosis of MODY is strongly suspected, but no mutation is found by DNA sequencing. So this is the thing about monogenic forms of diabetes, especially what I covered is MODY. There are few questions. If you want, I can put this. I think it's already 10:30. So did you get, are you able to follow the class? Are you all there?
Yes, ma'am.
Just woke up, or you understood what happened in the class? Are you able to follow? At least
Yes,
you
ma'am.
remember the only one slide which I told you to remember, that one you have to remember. Other than that, if you forget everything also, no problem. Just remember the MODY first 5 types at least. Okay? Okay, thank you then. Any doubts you just put there, and now attendance also you can put in the chat box. ఎప్పుడు పెట్టినా 4%. ఒకవేళ కేసులు ఎక్కువ ఉంటే పెడతాను నేను, మీరు పంపించండి డీటెయిల్స్.
క్లోజ్ చేసి వచ్చి
అయిపోయింది మరి అటెండెన్స్.
ఓకే జస్ట్